Welcome to session 121 of the Weekly Huddle. I am Dr. Praneeth. I'm a cardiologist working at KIMS Hospital, Secunderabad. I am joined by my colleague and co-host, Dr. Anoop Agrawal, who works with me at KIMS Hospital. We've been hosting this Weekly Huddle session for quite some time, and most of you are familiar with the pattern of the program. We discuss a clinical topic and try to know the science behind it. We try to reframe our way we are conducting sessions. As per the review, as per the so-called survey, specialty topics need to be discussed was what the need of the hour. So we thought of discussing specialty topics. Today is one of those specialty topic, probably a cardiology heavy topic, I should say. We're talking about aortic stenosis, about decision making, about valve replacement, and what is the who is the ideal candidate for valve replacement, be it surgical or percutaneous. We'll try to make this discussion on case-based. So I'll try to elaborate a case, and we'll try to discuss with this case into picture. I can see Somraju sir and Amir, who I can identify as cardiologists, and Anoop is there anyway, and others I cannot recognize. So I'll try to take comments from Anoop, who is a proctor himself for TAVR. So I think I'll take his opinion, and equally, if anybody has any questions or any doubts in between, can interfere and please get it clarified. So we'll get started. So this case, who we saw recently, this patient is a 64 male who got recently admitted for heart failure. It's a decompensated heart failure where the patient was stabilized. And as a routine for any patient who has heart failure hospitalization, you try to look at why did the patient have heart failure, and you try to look at any correctable causes. On evaluation of this patient, the patient was found to be having a severe valvular aortic stenosis with a peak gradient of 84 and a mean gradient of 48, a valve area of 0.8. Echo showed moderate LV systolic dysfunction, and there was also a moderate mitral regurgitation. There was an enlarged left atrium. The right ventricular function was okay. There was a mild pulmonary hypertension with an RV systolic pressure of 55 millimeters. ECG showed sinus rhythm, some left ventricular hypertrophy. There was poor R wave progression in anterior precordial leads. When we go back to his past history, he's hypertensive, diabetic for more than 10 years, and he had an antral MI about 5 years back, for which he underwent thrombolysis. Later, he underwent an elective angiogram followed by angioplasty to his proximal LAD. The last details that we know, his ejection fraction was about 50%. And this report, we had it about 2 years back. He was recently diagnosed to be also having chronic kidney disease with a baseline creatinine of 1.9. He is non-oliguric and he is otherwise okay. And he also follows up with his physician and nephrologist, who is continuing conservative management. Now, this patient who got admitted for heart failure hospitalization after initial stabilization because of severe aortic stenosis, he was evaluated for aortic valve replacement. As a part of evaluation, because of his previous history of coronary artery disease, a coronary angiogram was done to assess the coronary artery disease. A diagnostic coronary angiogram was done, which showed that the stent in LAD, which was placed 5 years back, is patent. There's a lesion in left circumflex in the proximal segment with about 80% stenosis with TIMI3 flow, good flow. Right coronary artery was normal. Now, this gentleman who just recently got retired is a CGHS employee, non-vegetarian, lives in the outskirts of Hyderabad with his family, with his son and grandchildren. And he is reasonably physically active, who does his daily chores, does his daily activity, and he wants to lead an independent life. Now, for this patient, who is reasonably okay, physically well-built, whose frailty index is 0 out of 4, who had a heart failure hospitalization because of severe aortic stenosis with moderate LV dysfunction. How do we manage this patient? What is the I think the decision of doing aortic valve replacement is clear. There is no confusion in that. But how do we replace this valve? Today, we know that there is two options, which is the gold standard surgical aortic valve replacement and the new kid in the block, which is the transcatheter aortic valve replacement. Now, how do we select which one should be offered and what are the pros and cons of each therapy? Understanding everything from surgical risk to cost to practical aspects of it. The data that we have is heavily dependent on the literature that we get from European and American patients. How can we translate that data into Indian patients and make it more practical? And how does a physician who is seeing can make a decision or refer to a cardiologist? So these will be the essence of discussion today. So I will probably start with Sadiq, whom I can see as a cardiologist. Sadiq, if you can unmute yourself, thank you for joining. And can I get your input on if this patient? I don't know whether you could completely hear this story. If you think there is any questions that I can say, I can give you inputs and you can understand the case better and give your inputs. Can I get your comment, Sadiq?
Yes, thank you. So I just joined. So I understand that this is a patient with moderate LV dysfunction who already had a anterior MI that was stented, and now he's got moderate MR with severe aortic stenosis and moderate LV with moderate PH. Am I right?
Yes.
Yeah. So yeah, I think because this frailty index is 0.4, and he has got LCH lesion of 80% with moderate MR. Probably we need to understand the cause of the mitral regurg in this patient first before we proceed further. Because I think fixing the mitral valve is not going to solve the problem here. Maybe we revascularize the circ, reassess the MR, then deal with the aortic valve. I feel the MR could just settle once the LVOT obstruction is taken care of.
Okay. Anything else you would like to add, sir?
I think LCX lesion probably, we should revascularize that. And yes, I don't think I would go for surgical AVR in this patient because, nothing as of now.
Okay, so if I understand you correctly, then you would opt for transcatheter valve replacement, probably do a coronary artery disease intervention, and for mitral valve regurgitation, you would probably reassess after you are intervening both coronary artery disease and valvular stenosis, and you expect the valve regurgitation to come down post intervention, post addressing valve stenosis and coronary artery disease.
Yes. I feel it will come down.
Okay. Thank you for those comments, Sadiq. Now, with this opening remarks, I would probably try to understand from Anoop. Anoop, can you help us understand, decode these things? I'll try to break down for the sake of clarity, or this is what equally I have in mind when I look at a patient. Like, how can we make a decision of offering valve replacement option, surgical versus transcatheter valve replacement? If we go back in time, transcatheter valve replacement, when it was introduced, it was indicated for only extremely high-risk patients, and then followed by high-risk and intermediate and low risk. And these risk calculation was based on the surgical risk, based on the STS risk score. and that is where it is. And currently, as per the recommendations or guidelines, and now TAVR is open for everybody. It is for all comers, and it is there. Anoop, can you help us understand what is this STS risk scoring? How much is it reliable, and do we need to calculate to everybody? And how much can it how much can it help us in making a decision? Can we solely rely on it? Do we need to calculate it, or how is it relevant in Indian patients?
Right, Pranit. So I think in this patient, one part is very clear: is this guy needs aortic valve replacement. When to do, how to do that, we can discuss about it. So, as you all are quite familiar, the evolution of TAVR in the last 12 years or so, because the trials were done in a certain surgical risk profile, it basically forced us to think about surgical risk score or anticipated surgical risk before we consider whether the patient should be offered TAVR or not. And the idea here was, we do need to offer a therapy which is perceivably having a lower risk than surgical AVR. That's the whole idea behind, because surgical AVR was the gold standard. So if surgical AVR can be done at a much lower risk, then why do we necessarily offer TAVR? One gold standard therapy is already established. Just because it's a minimal invasive, that doesn't mean it needs to be offered to everybody. So we were, in our clinical decision making, we were forced to think about STS risk score or Euro score. Why those scores? Because those were the only available validated scores at that time, which had got certain predictive value of what a 30-day mortality would be if this patient has to undergo a surgical aortic valve replacement. So that is how the STS risk score or the Euro score became a part and parcel. In fact, cardiologists started using this score more than the surgeons about 10 years ago. Subsequently, as TAVR evolved and as we started incorporating this therapy in more and more lower risk subset, intermediate risk, and then low risk subset, what we started realizing is that TAVR is performing equally, if not better, than surgery in terms of perioperative outcome. So long-term outcome that we can discuss about, but perioperative outcome, which earlier, about 10, 12 years ago, we were not quite clear how TAVR will phase out. But now we know that TAVR perioperatively does very good, does as good, if not better than surgery. So then it got incorporated into low surgical risk patient. The only problem was that we still did not know the long-term effect of TAVR. We understood the short-term effect of TAVR. We didn't understand the long-term effect of TAVR. So in the current era, now we are going away from the STS risk score categories, which would define whether patient should be offered TAVR or SAVR. Now we are going more towards patient longevity. And the idea here is, because it's a bioprosthetic valve, you expect this valve to degenerate. Whether it will degenerate in 10 years, 12 years, 15 years, we don't know that. But we expect this valve to degenerate. So if you have a patient, and if you think the valve is going to outlast the expected longevity of the patient himself, then STS risk score doesn't really matter. You are going to give the person a therapy, and that therapy is most likely going to be definitive therapy for this person's rest of the life. On the other hand, if you have a patient where you think that it can be expected for that particular patient to outlive the bioprosthetic valve, then there comes the discussion whether this patient should get TAVR or whether this patient should get a surgical valve, understanding that surgical valve will also be a bioprosthetic valve at that particular age point. But at least that surgical aortic valve has a much better legacy. And so we know we are actually offering them a therapy which has been tested over time as compared to TAVR. And we know that TAVR can be done once the bioprosthetic valve fails. So in the current era, STS risk score is less relevant in our clinical decision making. What is more relevant is, can we get a reasonable estimate of patient's life expectancy and then make a decision accordingly. One question you asked about the limitations of STS score, because we are not doing STS scoring these days, we are not talking about the limitations that much, but it is important to know, because those limitations of STS score, if present in a patient, would put that patient at a high risk for surgery, and there, even with a low STS risk score, you would favor doing a transcatheter therapy in those patients as compared to surgical. And those entities which are not included in STS risk score, one thing you mentioned about frailty, but porcelain aorta, we have heard stories where a patient's chest was open and then was closed even without bypass surgery or without aortic valve replacement because surgeon identified there is a porcelain aorta, or those patients who had multiple thoracotomies before, or those patients who had chest radiation before, those patients who had significant kyphoscoliosis and all these chest deformities of any kind. So those patients, we know that while these entities are not included in STS risk score, they are considered very high risk for surgery. So if you have a patient with severe AS who has got these features, then everything else becomes secondary. You know this patient cannot go for surgery at a low risk, and we should be favoring TAVR in those particular patients. Back to you, please.
Yeah, no, I got attention when you told about trying to make a decision looking at the lifetime of the patient and not that particular event. Now, this patient is 64 years of age, who should still be considered as middle age, even by definition, anything more than 65. Thankfully, in Indian patients are also longevity is increasing, and even if you look at an average life expectancy, is close to 70 at this point of time. And if this patient, for the sake of discussion, we can probably think that he may have an expected life expectancy of 75, which is 10 years, or if more. So this patient who is 64, who is considered to be relatively young, based on the age criteria, is there any cutoff or any number that you think? Yes, he also has other comorbidities which makes the decision making, which come into picture in decision making. But if we look at age criteria in isolation, what do you think is the number that you consider surgery versus transcatheter if other variables are common between both? What is the age group when you prefer TAVR, and what is the age group where you prefer SAVR?
Okay, so I'll tell you the guidelines. The American Heart Association last year, it revised its guidelines, and there they put in the age cutoff of 65. Now that is for Caucasian people or patients, where what US guidelines suggests is that if you have a patient with severe AS with an age more than 65, then TAVR should be considered. It doesn't say TAVR should be favored over surgery. It says TAVR should be considered in age more than 65. If you have an age less than 65, then you should look at the risk algorithms or expected life expectancy and all those kind of things. The European guidelines, they kind of shook things a little bit this year when they released their guidelines after the American Heart Association guidelines were released, and European guidelines put a cutoff of 75, where they said that age less than 75, surgery should be preferred, and age more than 75, TAVR should be preferred. So they did not give they did not give a room for discussion. They pretty much said that any person age more than 75, we should favor TAVR in those patients, and any person less than 75, we should favor surgery on those patients. Now, these age cutoffs are based upon their patient profile, their life expectancy, their medical system, and whatnot. When we talk about in India, we have to take it with a pinch of salt. Now, while I do understand that overall India's national life expectancy is about 69 years, what we have to understand is the kind of patient who come to us for severe AS treatment, considering TAVR, they belong to that patient subset where you expect their life expectancy to be higher than national average. So I can't take 69 as the expected life for the patient whom I'm considering for TAVR. These patients, I expect them to live 75 or maybe even 80, even beyond that. So I wouldn't particularly take national life expectancy in this clinical context. Having said that, let us think from the Indian perspective. You have a patient where you would think that if you take 80 as a cutoff for a reasonable life expectancy in a person whom you are evaluating at age 60, 65, because diseases, they catch up. There is an index called Charleston Comorbidity Index. Anybody can Google it. Basically, what it does is it looks at individual person's comorbidities, any of them, CKD, lung dysfunction, liver dysfunction, whatnot. And then it says that based upon the background comorbidities, you can kind of calculate their overall life expectancy at whatever given age. You can put an age of 60, you can put an age of 70, and it gives you a comorbidity index with which you would, it says that if you have these many comorbidities, there won't be an ideal scenario where you will live for 20 years or 30 years. There will be other problems which will catch up with you. There could be intercurrent illness that will catch up with you. So in India, if I have a person who is absolutely healthy at age 65, I have no reason to believe why that person will not go beyond 80 years of age. Just because the national average is 69, that doesn't mean anything. The index case that we are talking about, imagine this is, let's say this patient did not have severe AS. If this patient had whatever other comorbidities we talked about, this patient had an anterior wall MI, probably his anterior wall, at least part of it is dead because his ejection fraction was slightly lower even a couple of years back. This patient has all the comorbidities. He has diabetes, he has hypertension, he has CKD with a creatinine of 1.9. If you just put these things into perspective, you cannot expect this patient to live for 20 years without any major problem. That is, I'm just talking about statistics. There will be patients who will outlive those. There will be patients who won't live as much. But these comorbidities are going to catch up with him. And on the top of it, he has got severe AS, which we know has got poor outcome if it is untreated. So if I have to put, I would say this patient probably has a life expectancy of around 15 years. If he outlives, maybe 20, but that is stretching too much. I think that at this point of time, one bioprosthetic valve for him, be it surgical or be it TAVR, may be going edge to his life expectancy based upon his comorbidities. That will be my judgment when I see a patient like him, Pranit.
Yeah, so because he's relatively young and if his surgical risk is considered to be acceptable, probably doing a surgical valve replacement with a bioprosthetic valve, and in next 10 years is probably if he gets degenerated, then we can consider doing a TAVR at this point of time when age increases and where TAVR will be preferred. This is what if we took age as a criteria, if I understand correctly, but that alone should not be considered, and other risk factors also need to be taken into consideration. Now, moving for other risk factors, if you look into this, the LV dysfunction. This patient is having moderate LV dysfunction. The last that we know is 2 years back, his LV function was reasonably okay, about 50%, which is quite acceptable. Now it has dropped to about 38%. Now, probably the only reason why we can explain is this new entity, aortic stenosis, which has come into picture, and probably that is the cause for his LV dysfunction. And probably after replacing the valve, his LV function is most likely going to improve, if not normal, close to normal. Now, the two problems of replacing the valve, like when we do valve replacement, you are going to occlude the valve by your transcatheter valve, be it a balloon expandable valve or a self-expandable valve, which to a certain extent, even for that brief moment, can literally obstruct the outflow from LV into aorta. If the patient does not have significant LV reserve, then this LV dysfunction may probably aggravate his condition, and there could be a reason for events on table. If I understand it correctly, then do you think this patient will be better off going for surgical valve replacement, where patient is put into a bypass machine, that LV can relax, you replace the valve, and now because the obstruction is relieved and his LV can better recover? Do you think by doing a transcatheter valve replacement in a patient who is having LV dysfunction, does this make a decision to prefer surgery or surgical valve replacement or a transcatheter valve? How does LV function come into picture in making a decision?
So, to answer this question, I can take you back to the trials which were done with high surgical risk patients. And one of the major determinant of high surgical risk was low LV ejection fraction. And we know that in patients with high surgical risk, TAVR fares better than surgery. So the concern of obstructing the outflow momentarily while you are deploying the valve, that concern, I think, is out of place. All of the valves that we deploy, if we are doing a balloon expandable valve, then we typically pace the ventricle so that we effectively reduce the cardiac output. So it's not that the LV is fighting against an obstruction. And that pacing run is hardly for 30-40 seconds. So it is too short for the LV to go stunned. And then there are valves these days which do not require pacing at all. We have self-expandable valves where the LV outflow obstruction does not occur at all. And in those patients, you can very safely replace a diseased valve with a normal functioning valve. Now, talking about surgery, whenever we send patients for surgery who has got one index problem, like in this case, severe AS, or in coronary artery disease case, it could be coronary artery disease. When we send a person for surgery with an index problem to be fixed, and if that heart has got other concurrent problems, like LV dysfunction, like mitral regurgitation, tricuspid regurgitation, or pulmonary hypertension and whatnot, we know that the surgical outcomes are heavily dependent upon what happens to those other parameters once you fix the primary problem. Like, for example, if you have a patient with severe LV dysfunction or moderate LV dysfunction who has got severe coronary artery disease, when this patient goes for CABG, then what surgeon knows for sure is that once you revascularize those arteries, this LV over the next 24 to 48 hours is going to improve, and that will help the surgeon recover this patient faster. That is why surgeons hesitate to take patients of ischemic heart disease who has got a demonstrably dead myocardium to surgery, because they know that even after surgery, the chances of LV recovering in the short term is less. And because of that, it will be difficult for the surgeon to get the patient out of the ICU. Forget out of the ICU, even out of cardiopulmonary bypass. Now, in this particular case, you have got a patient who has got some LV dysfunction. We can assume that part of it is old ischemia. Whether part of it is because of new ischemia related to circumflex, that we don't know yet. At least he doesn't have any anginal symptoms in the history. And part of it is because of severe AS, and that is also irreversible or reversible. That part is also not very clear. And at this point, we know that we really don't have good tools to identify whether the LV is going to recover or not. So you have a patient with an ejection fraction of 35 to 40%. Some part of it most likely is dead. Some part of it could be salvageable. And then you have a mitral regurgitation, which by itself does not meet the criteria of replacement. But once a surgeon goes in, then the chances of the surgeon getting this patient out of ICU will depend upon how good the LV is functioning, how good the other valves are functioning. So many of the times, a 3+ MR surgeon is forced to repair by a ring or do a replacement, because leaking a 3+ MR in post-op day 0 or post-op day 1 is going to be very difficult for that surgeon to get out of that initial recovery period. So in these patients where you not only have an index problem, but you have other associated problems with the heart, unless they magically recover immediately post-surgery, the first 1 to 2 days or maybe 3 days, you can expect it to be stormy after a thoracotomy, after an open heart surgery, vis-a-vis TAVR, which has got a very transient 30 to 40 second what you call penalty to the myocardium, which most of the time the heart tolerates quite well. So in these scenarios, I would much more favor TAVR over surgery, understanding that TAVR is going to be safer both physiologically and also data-wise. Surgery is challenging. In fact, a lot of these surgical cases, they have to put mechanical support for at least first 24 to 48 hours till the myocardium recovers. either because of the afterload reduction or because of revascularization or because of MR reduction or whatnot. Sometimes myocardium takes a day or two, and during that time, you have to give mechanically support either in the form of IABP or in the form of an external pump. Sometimes we put Impella in those cases. Sometimes you can put ECMO in those cases, or a portable, what you call cardiopulmonary bypass. You put them just so that the myocardium recovers or takes time to recover out of it. So in these kind of scenarios, Praneeth, definitely TAVR would fare over surgery. I'll give you one exception. You have a patient who has a demonstrable normal LV a year or two ago, now developed severe AS and has got LV dysfunction. There is no other concomitant pathology. In those patients, you expect the left ventricle to improve very soon after the aortic valve is replaced. So those patients sending for surgery is less of a problem than these kinds of patients who have got myocardial disease both ways, both ischemia as well as valve, and also has a concomitant another valve pathology, which by itself does not need replacement. But once you go in, surgeon may have to do something. Otherwise, it will be difficult for that surgeon to get out of the cardiopulmonary bypass.
Okay. When the other aspect which you were telling is about the mitral regurgitation. This patient has moderate mitral regurgitation, which was a concern for Dr. Sadiq as well. Now, ideally, when a patient has two valve lesions, one of them is severe and one of them is moderate, surgery becomes the treatment of choice, where you address both the valves. Now, this patient has severe aortic stenosis, which is an indication for sternotomy, and because patient had underwent sternotomy, you also address the mitral regurgitation, though it is not severe, but it is going to become severe in the future. So you do not want to subject the patient for a redo sternotomy. You address that other moderately severe valve lesion as well. So because this patient has severe AS and moderate MR, surgery should be the preferred treatment of choice to do that. Sadiq said that his mitral regurgitation could be probably because of coronary artery disease and aortic stenosis. What are your thoughts on it? A moderate mitral regurgitation, do we need to really worry? Do we need to evaluate? Is it going to progress, or is it going to regress, or is it going to stay the same? And how does it play a role in making a decision of surgical valve replacement versus TAVR?
So, this particular patient, it is highly unlikely for this patient to go for surgery and only come out of AVR. This patient will most likely require an AVR, a single vessel bypass to his circumflex, and most likely a mitral valve repair, possibly replacement, repair in the form of ring repair. So this patient is not going to have isolated SAVR. It will be a SAVR plus a mitral valve repair with a ring plus a single vessel bypass. What we have not established yet is what is the etiology of this MR. And while I'm saying we have not established yet, it may not be that easy also for us to pinpoint exactly where the MR is coming from. A part of it is ischemic because circumflex has got a lesion, but most of it, if I have to make a guess, is probably secondary to the annular dilatation, probably secondary to the left ventricular dilatation because of poor ejection fraction and whatnot. We do know that severe AS patients, they tend to have a higher LV diastolic pressures, and that also drives the mitral regurgitation every time when the ventricle contracts during systole. So what we have seen in the data set is if mitral valve does not have intrinsic pathology, that is, if it does not have any organic disease, you don't have a tethered leaflet, you don't have a mitral valve prolapse, you don't have a caudal rupture, you don't have those kind of things, unless the mitral valve has a structural damage. Most of the scenarios after TAVR, you see 1 to 2 point reduction in mitral regurgitation, which is if you start with a 3+ MR, you would expect the MR to come down to 2+ or 1+. And we are okay leaving MR at 3 or 4 plus even during TAVR, because we are not putting a patient on cardiopulmonary bypass. We are not putting the patient for a thoracotomy. Surgeon does not have that luxury to leave, because he will have difficult time getting the patient out of the bypass machine and out of the cardiothoracic ICU. So in this particular patient, you would give him a benefit of doubt. You have to revascularize that circumflex. If you go percutaneous, you do with a PCI. If you do surgical, you have to do a bypass. And if you are going percutaneous, you can do a TAVR. And with that, what you have done is you have taken care of myocardium from both the sides, both from the aortic valve side, also from the ischemia side. And with that, you would expect this MR to improve. I would definitely do a TE on this patient to make sure there is no major structural valve abnormality, which if present, then TAVR is unlikely to make this MR better. And in that case, you can argue whether surgery may be a better idea by doing a double valve replacement. When you do that, you also have to take that surgical risk into account, because now when you are doing a SAVR plus a mitral valve replacement plus a single vessel bypass, you're talking about a pump time of somewhere around 3 hours, 3.5 hours, maybe even 4 hours. And we know that as the pump time increases beyond 2 hours, it adds to the cardiac risk, it adds to the overall mortality quite a lot. So those are the parameters that you do need to think. In this case, if you go percutaneous, you do revascularization to circumflex, you do TAVR to the aortic stenosis, and there is overwhelming chance that the mitral regurgitation is going to get better if there is no structural abnormality present.
Sadiq, do you have anything to add or have any comment?
Yeah, sir. Actually, yeah. So for me, the whole, the decision to go for TAVR over a surgical valve is probably the same reason that, once you do end up opening up the patient, you don't really have the luxury of doing a single valve and coming out. And I feel that in the presence of moderate MR, we are actually overestimating the LV function. It's likely to be much worse than what we have detected at 30%, because now the LV is decompressing into the LA, which is because of the incompetent mitral valve. So once we really don't know how severe the LV function actually is. And I feel that once you do relieve the LVOT obstruction and the LVEDP drops, it's very, very likely that the MR will regress. And of course, we do take care of the ischemic component also by revascularizing the circ. So I feel that will help. If this was a patient with a good LV function, I would probably lean a little more towards a surgical repair. But in the presence of a moderate LV dysfunction with moderate MR, I think surgery would not probably be the first option. I would like to go for a transcutaneous replacement rather than sending the patient for an open surgery.
Yeah, point taken, Sadiq. Agree with what you said. Now, you mentioned about coronary artery disease. Now, again, this is something which is equally bothering, particularly with the mitral regurgitation and the drop in ejection fraction. Now, we don't know which is contributing to the drop in his ejection fraction, be it aortic stenosis or be it coronary artery disease. And circumflex, we know, supplies the posterolateral wall, which can lead to papillary muscle dysfunction, which can produce a mitral regurgitation. Now, if this coronary artery disease, which is the circumflex territory, is significant, now we don't know about how significant it is. We probably have to do some investigation, but it is anatomically, it looks severe enough. How do we address that? And in relation to aortic stenosis, now in a patient who has an aortic stenosis and coronary artery disease, should we address both or should we stage it? And if we have to stage it, which should come first? Coronary artery disease treatment first, or valve disease first, or CAD first? How do we make a decision? How do we evaluate presence of coronary artery disease in relation to severe aortic stenosis? Anoop, would you like to answer?
Yeah, Praneeth. So, the data that we had in the recent years that makes it very clear that doing PCI to residual coronary arteries, which is asymptomatic, versus leaving it alone in the short term, do not have any penalty. So I want to emphasize each of these terms very carefully. The coronary artery disease needs to be asymptomatic. That is number one, which, as we discuss in this case, is at times very difficult to prove either for or against. But an asymptomatic coronary artery disease, whether you do a PCI or whether you leave it alone, in the short term, and I think we have the data for up to 2 years, do not have any penalty to pay. What happens after 2 years, we don't know. But definitely up to 2 years, the data supports that you can leave it alone. What we end up doing in our clinical practice is that if you have a lesion which historically has been associated with higher mortality, which is your left main stenosis, your proximal stenosis, or your triple vessel disease. These are the three entities which we know, even if asymptomatic, they are associated with higher mortality. In those patient subset, we tend to do angioplasty, even if asymptomatic, before we do TAVR. You can do both the procedures on the same sitting, or you can do PCI first and then you do TAVR. We typically don't do TAVR first and then do PCI, because doing PCI after TAVR becomes a little challenging, because now you have a valve frame sitting on the way. So typically we do PCI first and then we do TAVR. So only two situations where PCI can be suggested by expert consensus. One is if there is obvious reason to believe that this coronary artery disease is causing symptoms, either in the form of angina, or in this particular case, where we are implicating that it could be causing ischemic heart disease, plus minus mitral regurgitation. So in this kind of subset, you are validated to do PCI, which should be done either before TAVR or as a combo procedure with the TAVR. The second situation, which question is not yet answered, and that is high risk anatomy for coronary artery disease. That is your proximal, left main, or triple vessel disease. In those situations, we normally do angioplasty, even in asymptomatic cases. Even in TAVR, we would do that. So a mid-LAD asymptomatic, or a mid-RCA asymptomatic, or even for that matter, CIRC asymptomatic, at this point of time, based upon the data, you can leave it. You'll most likely be okay. Again, you have to recollect that this is only a short-term data. Long-term, how do they do? We don't know that much. So a little bit of clinical decision-making at a personalized level also has to take into play. Guidelines do not give us a very clear idea in this particular subset.
Yeah, so doing intervention in this case, so in case if we thought that coronary artery disease is significant and the patient needs a percutaneous coronary intervention and a valve replacement by TAVR, which can be done. Now, the problem for doing a percutaneous intervention for every interventional cardiologist is the functioning of the kidney, because we will be injecting contrast, and essentially that contrast will be ejected out of kidney, and you want the functionality of kidney to be intact. This patient who has a creatinine of 1.9, stable chronic kidney disease, stage 3, if we have to say. Now, the risk of contrast injury or contrast associated nephropathy in case patient goes for TAVR. Equally, the problem of ischemia when the patient goes for surgical valve replacement. Because you do cross clamping of aorta, there is ischemia to kidneys, which can equally lead to kidney damage. So either way, there is a risk of kidneys getting affected, either of the treatment modalities. Now, out of the two devils that are there, which one can hurt his kidneys more, or how do we make a decision in relation to kidney safety? Because nephrologists would be unhappy when we test his kidneys. So which of these are higher risk of producing kidney damage, and how do we make a decision of SAVR versus TAVR when it comes to chronic kidney disease?
Okay, so when we were talking about high surgical risk for STS, one of the prime determinant other than age was LV dysfunction. The other one was CKD. We know that surgeons don't like CKD. Surgeons want the kidneys to be functioning very well. CKD is one of the major determinant of what the outcome is going to be post-surgery. We do know that there is temporary deterioration of the GFR, and eventually either it will recover or it may even get better. What we also know in severe AS patients is that these patients have this chronic cardiorenal syndrome where their creatinine, because of their hypoperfused state, they typically tend to function less. There was a recent large data which was published which proved this point, that 89% of patients with CKD who underwent TAVR had an improvement in their kidney function, which is remarkable. Basically, what that tells is, if you take 100 patients with CKD and you subject them to TAVR with all the contrast load and everything, probably because of improved cardiac output, because of improved renal function, overall improved mechanics of the body, the majority of them, almost 90% of the them, 9 out of 10 patients, you would expect their creatinine to improve. This is contrary to what you see in the surgical outcome. And in fact, amongst the various morbidities where TAVR outshines surgery other than atrial fibrillation, AKI is one of them, where the chances of kidney deterioration is much lower with TAVR as compared to surgery. Granted that when you give contrast, then you are actually torturing the kidneys. What I tell patients is, if you are doing a contrast procedure, then try not to delay your TAVR after that. Try to combine a lot of things together so that increased cardiac output gives your kidneys the best chance to recover. So if this particular patient, if I have to plan the procedure, I would plan CT followed by, because CT TAVR protocol is a mandatory thing in all of these patients, CT followed by angioplasty and TAVR. I'll try to plan it back to back, because I want to give this kidney the best cardiac output possible as soon as possible, so that it has the best chance to recover. The worst thing that we do is we do a CT scan on a patient who has CKD. We subject them to contrast exposure and then don't do TAVR for 2-3 months. Now, basically, you have caused an insult to the kidney and has not benefited in any form. That is probably not the best idea. But most of these patients, and we have seen at least a few of our patients who were on established dialysis before TAVR, and after TAVR, their not only dialysis got stopped, their creatinine actually got much better. Not normal, but they got much better, and they are free of dialysis after TAVR. So chronic kidney disease hugely favors TAVR in whatever form you look at it.
Okay, considering everything, like if we look at this patient holistically, all the factors taken into consideration, TAVR seems to be a preferred treatment option for him in comparison to TAVR. So now that the patient is okay to do TAVR, we need to discuss TAVR. We need to discuss about the practical aspects of getting the TAVR done. Now, this patient who is a CGHS employee who got recently retired, he stays about 100 kilometers away from the main part of the city. And now the most important thing whenever we talk about TAVR is the cost. From the surgical aspect of it, when we do surgery, we want patient to be in close proximity at least within the first 1 month, because we want patient to be, we want to ensure that his post-operative course is smooth, the wounds are healing fine, and he's not having any immediate outcomes, for which his stay outside the city will be cumbersome. But we encourage patients to probably take a lodge or something and stay close, or maybe hire a place in the relatives. So that part is manageable for him. Now, the most important part is the cost. For a CGHS beneficiary in Hyderabad, at least, the surgical valve replacement is free of cost, so he need not spend any money. TAVR otherwise is going to be expensive. It is at least 15 lakhs or more. So this is zero cost versus 15 lakhs of cost. Now, how do you justify or the so-called risk that this patient has to take to undergo a zero-cost surgical valve replacement versus a less risky treatment, which is a bit of a significant expense even in today's standards? How do you convince this patient, or how do you bring this discussion, or how do you talk to this patient about treatment option?
So there is no discussion of TAVR complete without talking about cost. There is no doubts about it. The cost still remains very high. And in this kind of patient subset where one therapy is more or less free and the other therapy costs an arm and a length, it is a relevant discussion. Whenever we talk about cost, there are 2-3 aspects that I want to highlight. Number one, the cost of therapy as a general, which somebody pays, not necessarily a patient, but somebody pays, and an out-of-pocket expenditure. So in this particular patient, I am almost certain that cost of therapy of surgery will be higher than TAVR in the first year. If you take the total cost in 1 year, the surgical cost is going to exceed TAVR, both by the surgical charges and also post-surgery follow-up, some certain complications, whatnot, and all of this. So each of these is going to add the days lost in recovery and whatnot. So overall, in 1 year, the TAVR cost will pay for itself. The problem is, while this is a system cost, every single cost that I mentioned will not be a patient's out-of-pocket cost. The out-of-pocket cost, which what we see for this patient, is remarkably different when you go for surgery versus, like for this patient, if he goes for surgery, and let us say in 1 year, he has 1 or 2 readmission for either a sternal wound infection or maybe some heart failure or whatnot, these are all zero cost for him. Somebody is paying, but for him, it's a zero cost. So the overall cost of therapy will be high for surgery, but the out-of-pocket expense will be much lower for this particular patient. So what he has to look into, and that is again part of the counseling, is what is overall financial status for this particular patient. If this patient does not mind going through surgery with its comorbidity, taking some higher risk of mortality, the surgical mortality, and going through a long recovery process, maybe requiring more hospital assistance, but all of that without much cost to him, versus getting a procedure which is low risk, which has got lower morbidity, but it will add an upfront cost to him. That is something which becomes a personal decision. We can help them make that decision, but unfortunately, we should not be making decision for them. We can put all the perspectives into in front of him and let that person take a call in terms of which is better for that particular patient.
Yeah, no, I think these are all the questions that I had in relation to this patient. Like, this is how I look at each and every component. How much is it going to make a difference? So I'll probably pause here for a minute, take comments from others. If I think the forum is open for discussion. If anybody has any questions to me or Anoop, or any other questions or points that which we might have missed, please bring it up and we can discuss it. And while you are gathering your thoughts, maybe I invite Dr. Somraju sir for his comments. So sir, your comments, how much you agree or disagree, and if there's anything that we have missed or you want to make any corrections, please share your comments.
Thank you, Pranit and Anoop. It's a very nice that you decided to bring in this issue. I just wanted to make a comment on the number of people attending this session is very disappointing, but they can't take shelter under saying that it is a cardiology topic. And it is a primary practitioner, a physician, and any other specialties, wherever they are practicing, they face this problem and they are not attending is part of the serious problem of medicine. And we have serious issues related to our attitudes and our education. And this is continuously disappointing for me. And I can't tell you more, I can't tell you less. It's extremely disappointing. They have to make these decisions also apart from cardiologists. And don't give credit to them and don't excuse them for not attending because it's a cardiology topic. I don't agree with it. Having said that, that is the serious issue with medicine is that. Having said that, I only most of the issues that we already discussed is a wonderful discussion, and I learned a few things from your discussion. But I just wanted to point out on issue of mitral regurgitation, the setting of aortic stenosis. The aortic wall is obviously pathologic. As organic disease, it's a different issue. If the mitral regurgitation is not organic, the mitral regurgitation is related to aortic stenosis, LV dilatation, annular dilatation, left atrial dilatation. The issues are different. In this patient you are talking about, I just want to know what is the LV systolic pressure?
Sir, it was 110 millimeters of mercury.
What is gradient?
Gradient 84 by 54, sir.
When it is 84 by 54, what is the aortic pressure?
Sorry, sir?
What is the aortic pressure?
Aortic pressure, so the aortic systolic pressure is 110, sir. And the gradient is, mean gradient is 54, sir.
No, LV systolic pressure I'm asking.
LV systolic pressure will be 110 plus 80, which will be about 190 millimeters of mercury, sir.
So it's 190 millimeters of mercury LV systolic pressure. LV dilated, annulus dilated is a different issue than LV not dilated. LV function is otherwise normal. And then in this situation, the decision amongst various wall diseases, what we estimate, aortic stenosis, mitral stenosis, or aortic regurgitation. Mitral regurgitation is the most difficult lesion to evaluate as to the severity and issues related. Don't jump to conclusions as to what should be done to mitral regurgitation with the existing information and data. We have to individualize. Go by LV systolic pressure, go by annulus dilatation, go by say left atrial size, and then make the decision. Don't rush to make decisions on mitral wall in these patients and decisions on aortic wall in these patients blindly with the existing so-called guidelines. Thank you.
Thank you, sir. Shankar, sir, I would like to hear from you. Most of the aortic stenosis patients are seen or first diagnosed by the physician, and whenever a treatment decision is being made, the patients do take their primary physician's opinion with a lot of respect. So the whole point of discussion was to understand, and we wanted to kind of know how we think and what is the discussion that happens. So when every case of aortic stenosis is come, this is how we discuss in each and every aspect. So we wanted to bring in this discussion. So I would like to listen from you. How would you see this patient? How would you make a decision? And anything do you think that we need to include or we have missed? Shankar sir,
good evening to all. This is a very interesting case where a multidisciplinary heart valve team should be involved in this case to decide whether it is a TAVR or TAVR in this case. So because of high or prohibitive surgical risk in this case, in the form of many comorbidities, hypertension, diabetes, chronic kidney disease, and coronary artery disease, post-CABG, and the age is also 64 years, is not that young. So looking at this STS PROM, that is Society for the Thoracic Surgeons predicting the risk of mortality. Here it comes to be, I think it will be more than 8. In the fragility score, it is mentioned here, it is 0/4, but I don't think 0 is a robust health, because of this lot of comorbidities and post CBG and the LCX lesion and moderate MR and with moderate LV dysfunction. I don't think the fragility score measure it may be more than 2 or more than 3. So here organ system dysfunction is also there in the form of renal chronic kidney disease 3/3B. EGFR here it is 39 ml per minute. So looking at all these things, and is even in spite of all these comorbidities, his life expectancy is accepted with the quality of life. It will be more than 1 year. So taking into criteria of patients' preferences and values and a heart valve team disciplinary assessment and assessing the valve and vascular anatomy, if it is suitable, then I go for only TAVR. TAVR only. So second is he has got a LCX lesion. So this can be tackled by PCI. So once some prefer concomitant, some may prefer only staged procedure. So I as a general physician only with a little knowledge in this field, so I go for PCI first, then we go for TAVI. So regarding this, in the presence of ischemic cardiomyopathy, presence of MR, so the MR has to be tackled. So the edge-to-edge tip repair with the transcatheter. So first stage procedure, first I prefer PCI to the LCX lesion. Then second, we go for TAVR or TAVI. Then along with that TVMR, that is a transcatheter mitral valve repair, edge-to-edge repair at one sitting. This, after listening to the whole discussion, I think, can we think of in these lines, just as a staged procedure, first LCX, attending the LCX with the PCI, then go for TAVI or TAVR, then TVMR for the mitral valve repair. So this is my opinion, having gone through the learned discussion with the TAVRologists and the senior most cardiologist teacher, Dr. Somaraju sir.
Dr. Pranit, Dr. Shankar, I just wanted to add something here. As to the coronary artery disease, the lesions, what should be done in a patient like this? If the lesion is straightforward, above 75-80% or more, the issues are not much. But when the lesions are borderline, around 70% or around 65-70%, these borderline lesions, mind you, you are dealing with the LV systolic pressure of so high, LV end-diastolic pressure is also likely to be high, with mitral regurgitation and renal failure. And aortic diastolic pressure is also low. Even with borderline lesions, they become ischemic. Once the aortic valve is taken care of, these lesions which are borderline may not be of significance. They don't have angina, they do better, and then don't rush to deal with these lesions which are borderline at this point of time. They are 75-80% or more, it's a different issue. I agree with you on that issue. Thank you.
Thank you, sir.
Thank you, sir. Point well taken, sir. So we also thought the same. So we thought the coronary artery disease, though it looked anatomically significant, we thought it may be okay to manage medically, And as sir pointed out, once aortic stenosis is relieved, the coronary artery disease or ischemia will be much better. Regarding mitral regurgitation, also we thought that it was because the patient did not have any significant structural abnormality. We thought the MR was secondary, and we hope that the mitral regurgitation will at least stay same or maybe get better. The same has been communicated to the patient. And the coronary artery disease was also, the issue of coronary artery disease was also brought into the discussion. The risk of contrast nephropathy was also highlighted, and the overall longevity and the cost was discussed in detail to the patient. And proposal of transcatheter valve replacement was given to the patient. Regarding finances, patient had two sons who were working in US, and because he would get some aid from his two sons, he agreed to get TAVR done. So finally, this patient, with all the discussion, the decision is to do a transcatheter valve replacement for the aortic stenosis and medical management for the coronary artery disease, and close watch for the mitral regurgitation, maybe 6 to 8 weeks after transcatheter valve replacement. So this is what was done for this patient. It's 9:11. If there are any comments, I would be happy to take. We'll probably wait for a few seconds. And in the meantime, Anoop, you can give us the closing remarks and then we can end the session.
So we included TAVR as a part of our discussion because when we took feedback about huddle sessions, one of the feedback we got was that we should probably include more subspecialty topic. As you all recollect that in the first 119, 118 sessions, we were mostly trying to restrict ourselves for topics which are of general importance to all of us, regardless of our specialty. So discussing about TAVR was one of our attempts. I, of course, am biased because I am a TAVR operator, and I very fondly remember our times with Somaraju sir at CARE, where we started this whole program and all the ups and downs in 2017 and 18, where we were trying to establish TAVR at CARE and also at Hyderabad, where TAVR was very less known. So I, of course, have a conflict of interest, and on purpose, I was trying to avoid the discussion of TAVR on the weekly huddle, but now we did it. And this is no more a unicorn. I think TAVR is being done in pretty much most of the larger centers now. Some centers do less volume, some more, but as a general, TAVR is now ubiquitous. Now every cardiologist knows about it. And there are patients who come in after learning about it and they demand to get TAVR as compared to surgery because of its minimal invasive. So as what Somaraju sir was saying, this is not a topic which is restricted to cardiologists, physicians, and all other subspecialist doctors, because there may be their friends or family who would be taking their opinion about whether they should go for TAVR or surgery. While they may not be able to give the nitty-gritties of it, at least having a little bit of idea would definitely enable them to help their friends and family make a decision. So we thought it was a relevant topic, and for us, it's our conflict of interest, which I'm disclosing. But overall, I think I had fun at least discussing my thoughts in this session.
Yeah, thank you, Anoop. Weekly Huddle is hosted every Wednesday. We change our time 8 to 9 p.m. We will see you again next week with a new topic. Please do join. Thank you for attending. Have a good night. Thank you, everyone.